Morning. I'd like to welcome all of you who've joined our KOL call, Disease-Modifying Drugs for the Treatment of Type 1 Diabetes, featuring pediatric endocrinologist Dr. Michael Haller. My name is Keay Nakae. I'm the Director of Research and a Senior Healthcare Analyst here at Chardon. As call participants are aware, our focus at Chardon is on identifying companies that can generate exceptionally high long-term investment returns by creating shared value for society through disruptive innovation. Just to get some compliance issues out of the way, during this call, we will not be discussing Chardon research. Any discussions about research should be coordinated between a participant and their respective salesperson at Chardon. A recording of this call will be made available to clients afterwards. By participating in this call, our speaker attests that they have made Chardon aware of any potential conflicts, and they will not discuss any material, non-public, or confidential information that they are aware of that may breach their legal, regulatory, or fiduciary responsibility to any parties. With that said, for anybody in our audience who'd like to submit a question to ask of our speaker, please email it to me at knakae@chardon.com, and time permitting, I will try to ask it at the end of the call. So with all that out of the way, let's get started. First, Dr. Haller, thank you so much for joining us today. And to start, could I ask you to provide some introductory comments about your background and your involvement in type 1 diabetes patients in both your current clinical practice and in clinical trials?
Sure, thanks for having me on this morning. My name is Mike Haller. I'm Chief of Pediatric Endocrinology at the University of Florida, where I've been for 25 years, working primarily in the space of type 1 diabetes and immunotherapies. Our clinic follows around 1,200 children and young adults with type 1 diabetes, and our group has been involved in just about every type 1 diabetes immunotherapy trial that's been open over the last 20 plus years. In particular, we were one of the main TrialNet sites that led the work that resulted in teplizumab getting its label in stage 2. We've done numerous stage 3 studies and have led most of the studies in low-dose thymoglobulin. And so we're very excited to talk about the MELD-ATG study and the potential for SAB-142 moving forward.
Well, great. And maybe just to kind of lay a framework for those who maybe aren't quite as familiar with the intricacies of the disease, even though T1D is very prevalent, I'm sure most everybody here on the call knows somebody that is afflicted by it. Despite a lot of focus, investment, and research, it remains a significant health challenge. And what is it about this disease that has really hindered the development of breakthrough therapies?
Yeah, type 1 diabetes was, a uniformly fatal diagnosis before Banting and Best at Collip and McLeod discovered and were able to produce insulin in 1921. And really, for the 100 years following, we got much better at giving insulin and measuring glucose, but we really hadn't developed a true disease-modifying therapy, and there wasn't one approved until teplizumab was able to cross over that threshold. So type 1 diabetes is particularly challenging because it's a common enough disease. 1 in 300 people in the US get type 1. It does have a treatment modality, with insulin and continuous glucose monitors and insulin pumps now, making living with diabetes easier than it has ever been before, but it's still an incredibly challenging diagnosis, requires a ton of patient involvement, family involvement, and huge medical burden and costs. And so, it's a disease that we definitely would like to interdict meaningfully, not just to give therapies that treat the glucose part. It is an immune-mediated disease, but it's a very complicated pathway. It's not caused by a single gene. It's not caused by a single immune pathway. And there are many different flavors of type 1 diabetes, in fact. So, developing specific immunotherapeutics that go after particular targets has been challenging because the field has historically been a bit risk averse. And so for a while focused on antigen-specific therapies that were incredibly low risk, but also incredibly ineffective, before the pendulum swung back to more impactful immunotherapeutics that have now seen success. And so, the list of drugs that can actually preserve beta cell function in people with type 1 continues to grow. It's now 9 drugs and growing. And a few of them are now hopefully moving their way towards labeling and being able to be used under an FDA label. But the hill is definitely steep to climb to truly prevent or reverse the disease. We have a long ways till we're able to achieve that goal. And so we're really at the infancy of treating type 1 diabetes like the immune-mediated disease it is, rather than just giving insulin and measuring glucose.
Okay, well, great. So, while T1D actually exists on a continuum, disease progression is commonly described to occur in 3 stages, and new disease-modifying therapeutics seek to delay disease progression by stopping the immune system from attacking insulin-producing beta islet cells, thus protecting the existing functioning beta cells and possibly spurring on healthy beta cell growth. As you mentioned earlier, one of the most exciting new disease-modifying therapeutics is teplizumab, or commercially known as Tzield, a monoclonal antibody approved by the FDA in 2023. And I guess one of the early observations about this drug by Long and others was that type 1 diabetics treated with this monoclonal antibody, those exhibiting features of exhausted T cells were associated with the best response to treatment. So can you expand on this and maybe describe how this particular drug achieves this?
Yeah, so it looks like the majority of the immune therapies that have seen the most success in terms of preserving beta cell function do in fact induce T cell exhaustion. And there are a number of different ways to measure different markers on T cells that suggest they're exhausted. But in essence, it's turning down the intensity of the cell's ability to function in an autoimmune way. And so that is suggestive of a mechanism whereby you might see success for an autoimmune disease where you've got activated T cells attacking beta cells. And so teplizumab, by way of depleting T cells somewhat acutely, perhaps marginalizing them, removing them from the pancreas, the draining lymph node, but allowing the T cell repertoire to recover fairly quickly in T cell at least, looks like when the T cells come back, they are in fact more exhausted. And now we've seen that pattern with a handful of other drugs, and it seems to be one of the more predictive immune features of drugs that have seen success in preserving C-peptide.
So as I said, the drug was approved in 2023. You're very familiar with the drug. Can you describe how effective it is in delaying disease progression, and who's it really targeting?
Yeah, the drug was approved on the basis of a TrialNet study of just under 90 subjects who were in stage 2 of type 1 diabetes. So these are folks who had multiple autoantibodies and had dysglycemia, so not totally normal blood glucoses, but not high enough blood glucoses that they would qualify as having stage 3 or clinical type 1 diabetes. In that population receiving drug compared to the folks who got placebo, the patients who got teplizumab on the initial analysis had about a 2-year delay in progressing to stage 3. A subsequent analysis suggested that delay might be closer to 30 or 36 months. So, again, not a home run. We're not preventing disease indefinitely. But if you ask anybody who's lived with type 1 or anybody who has a family member with type 1, a 2 to 3 year delay in the need for insulin pretty much at any point in life, but you can think of many critical points, people will get very excited about that notion. And in fact, that is what ultimately won the day with the FDA. The FDA found that to be a compelling, clinically relevant benefit, even though a number of trials in stage 3 with teplizumab have already been completed and have repeatedly shown that it also preserves C-peptide in that group. But because it didn't lower hemoglobin A1C or lower insulin requirements, the FDA, has to date still been uncomfortable with the notion of giving an immunotherapeutic in type 1 a label solely on the purposes of it preserving C-peptide. Now, many of us in the field disagree with that and are continuing to push them to change their position. And I think they are. Not quickly enough for most of us, but that is why the drug is currently only approved in stage 2.
Okay, great. And with respect to its teplizumab's specific mechanism of action as a monoclonal antibody, what are maybe the positives or maybe some of the drawbacks of that approach? Specifically, maybe its effect on sustained lymphodepletion or its suppression of Treg cells.
Yeah, so teplizumab is a monoclonal antibody to CD3, so that's a marker on all T cells. So it is directed therapy in that sense. But you could also look at it as being fairly broad, because almost all T cells are going to have that expression, and be able to bind the antibody. And through a number of different mechanisms, those T cells are being acutely depleted or marginalized before they can come back. And when they come back in larger number, they again appear to be more exhausted. So that's the basis of the mechanism. The lymphodepletion that's resultant from teplizumab is actually very short-lived. Most of the patients who get treated with the drug, which requires a 14-day IV infusion, sort of have their nadir, their low point of lymphopenia somewhere between day 6 and 9, and then they actually start to come back to more normal lymphocyte levels by the end of the infusion, and certainly they're very normal within a couple weeks. So that's further evidence that you don't need lymphodepletion necessarily to provide immunomodulation that can have a meaningful impact on disease progression. And so that's an important thing to keep in mind as we consider the development of other drugs, that some may cause more lymphodepletion than others. And there are some arguments for why lymphodepletion might be advantageous, but it's very clearly not a requirement, given that we see that teplizumab is quite effective with only transient lymphodepletion.
Its effect on Treg cells.
The effect on Tregs, yeah, it doesn't appear to have a particularly impressive effect on Tregs. There's some relative Treg sparing, in fact, which may be one of the reasons why most of the immunomodulatory drugs that do work. It seems like they may shift the balance of functional regulatory T cells versus functional effector T cells, and basically shifting the balance more towards a tolerogenic phenotype for an individual patient. The challenge is that the patients in type 1 diabetes are essentially this very heterogeneous mix of immunophenotypes that we all label as type 1, and many of them respond differently. So even when we look at the teplizumab data, only about 2/3 of the treated patients really were what we would call responders and drove that positive outcome. Now that means 1/3 of the patients that you treat with this now FDA-approved drug are actually not going to get any meaningful benefit. And it's important thing that physicians and patients have to have open conversations about when they're deciding whether or not they want to go through and receive the therapy.
And then, with respect to safety, this drug side effects, common to what we might see with other monoclonal antibodies, but also has a risk of cytokine release syndrome. Certainly manageable, but a risk nonetheless. How much of an impediment have these been to its current adoption?
I think the risk profile is actually pretty reasonable for this drug, for any immunotherapeutic. For a drug to be able to deplete T cells, it's very likely it's going to induce some degree of cytokine release. It's just a different paradigm for endocrinologists who've never really given immunotherapies as a standard of care, where we're used to giving insulin or other things that manage glucose. So the notion of inducing an immune response can be a little off-putting to your average endocrinologist. And we're just at, like I said, sort of the infancy of this paradigm shift, where people are going to start to think of endocrinologists as also having to function like rheumatologists or other immunomodulator drug managers, and give these therapies. So the cytokine release is certainly very expected and not challenging to manage. On average, the typical patient has a low-grade fever or some nausea and headache, sometimes a little bit of a rash, but nothing that's not able to be managed almost always in the outpatient setting, with rare occasions. There is a small number of patients who do get liver function test, liver enzyme elevation abnormalities that can be significant enough that they have to discontinue the drugs before they complete the full course. And of course, there is a risk anytime we're giving immunomodulation like this that you could get a viral reactivation. And certainly we want to take patients who aren't in the middle of their primary Epstein-Barr virus infection, the virus that causes mononucleosis, and give them an immune modulating drug. And there have been a few cases where that's happened, and those patients definitely can have a prolonged course of a mono-like syndrome that can be much more severe than would otherwise have been. But as long as those precautions are taken and pre-infusion labs are obtained, I found that the side effect profile is not a big barrier to giving the drug. It certainly is something people, take pause with to make sure they understand. To me, the biggest barrier is actually the logistics and the cost. So the infusion of a 14-day drug every day for 14 days is, not a trivial thing. Again, for a field that isn't used to giving infused drugs like that, most of us in the endocrine world don't work with infusion centers beyond doing, stimulation testing. That's, a few hours, not many, many days in a row. Many infusion centers, if not most, are not open on weekends. So finding staff to come in and do the infusions to make sure you can do it 14 consecutive days has certainly been a challenge for my site and many others that I know are giving teplizumab. The complications of trying to do part of the infusion in a hospital infusion clinic and then part of it with a home healthcare agency is also a logistical challenge because it requires 2 insurance authorizations, which causes all kinds of unusual things to occur, where sometimes you get one entity approving and another not approving, even though it's the same patient under the same pretense of why they deserve to get the drug. I've run into that myself. And then, of course, the drug is just quite expensive on a retail basis at $194,000 for the course. And that's, of course, before hospital or infusion center markups. So it's not like it's something that people are going to run out and be able to get and pay retail for, with very rare exception. And that certainly has been a barrier for some folks who would like to receive it, but it's not labeled yet for folks who aren't stage 2 specifically. And so that excludes the vast majority of people with type 1 who still today don't find out they have type 1 until they're in stage 3.
Mhm. Okay. Well, great. Well, a different T cell targeting immunomodulator approach is to utilize a polyclonal antibody, and anti-thymocyte globulin, or ATG, at least a rabbit base, has been FDA approved to prevent transplant rejection. And this has been evaluated as a potential treatment of T1D in a number of clinical trials, including some that you've led. What are the potential advantages of utilizing a polyclonal mechanism of action?
Yeah, I like the polyclonal approach because I think it acknowledges how little we really understand about all the mechanisms that are involved in driving a single patient's immunophenotype. So it's a little bit, immune phenotype agnostic, essentially, because it does, by definition, target multiple different parts of the immune response. We've found that a very low dose compared to transplant dose is 2.5 milligram per kilogram dose in the trials that I've led, has been highly effective in preserving beta cell function in patients with new onset stage 3 type 1 diabetes. And because the thymoglobulin has been around for many, many years and is a standard of care for transplant rejection, it's given in almost every major medical center every day of the week. And so it is logistically, significantly easier to consider giving than teplizumab. It's a 2-day outpatient infusion. Granted, the infusions are 6 hours on day 1, 4 hours on day 2. So significantly longer than the 30-minute teplizumab infusion. But realistically, when you think about pre-medication, getting access, getting the drug, watching people for any post-infusion reactions, the total time on a day of getting teplizumab versus the time of day of getting a thymoglobulin aren't that different, with the exception, of course, that you only have to do thymoglobulin over 2 days compared to the 14 days. And then the other practical advantages of thymoglobulin are just that it's incredibly inexpensive relative to teplizumab. The downsides of it, though, are significant in that it doesn't have an FDA label for type 1, so it's completely off-label at this point. Very few people are offering it outside of a clinical trial that way, with the exception of my group. Um, it, and because of it not being FDA approved, you have to send patients to the places that are willing to do it, so that's a challenge. And then it still has the same cytokine release issues as teplizumab, so that's really no better or worse. But the one big difference that I would say rabbit thymoglobulin has, putting it in the negative category, is that it induces serum sickness because it is in fact a polyclonal mix of antibodies that come from rabbits that are anti-human. And once the human immune system recognizes that it's got rabbit antibodies floating around, it wants to get rid of them. And that process induces serum sickness, which is 3 to 4 days of rash, joint swelling, muscle cramping, achiness, general malaise that occurs 9 to 14 days after the 2-day infusion in around 70%, 75% of the patients. So that's an unpleasant side effect. It is self-limited. It's almost always manageable at home with medications to control the symptoms. And once you get past that 2-week window, we really haven't seen any long-term problems with giving rabbit thymo or teplizumab for that matter. But those are the differences sort of in how the drugs are delivered and their cost structure. So there definitely are people for whom rabbit thymo actually makes more sense than getting teplizumab. But because it's not a labeled drug yet, it becomes less available for many people.
So again, with ATG, as you mentioned, initially, too high of a dose, 6.5 mg per kg as evaluated in the START trial was found not to be beneficial. But then subsequent studies, such as the one you led, demonstrated that a lower, 2.5 mg per kg dose did preserve beta cell function and reduced HbA1c for 1 year. But can you describe the key findings from your study, and then also again how it ties into the notion that T cell exhaustion is a key feature that needs to be in existence for the beta cell preservation?
Yeah, so you mentioned the START trial, which was led by Steve Gittleman. That was an immune tolerance network study that used 6.5 milligram per kilogram of rabbit thymoglobulin in new onset type 1s. Again, still much, much lower than the transplant dose, but certainly a significantly immunopotent dose. And what we saw that was mechanistically different from that dose versus the 2.5 milligram per kilogram dose is at the higher dose, you wipe out effector T cells, which is certainly part of the goal, but you also wipe out the regulatory T cell component. And so it looks like you need a lower dose to reach this Goldilocks zone where you are preferentially removing more effectors, or at least functionally depleting them, maybe by exhausting them, and not depleting the regulatory T cell component. And in fact, that is the difference mechanistically that we saw in our pilot study in comparison to the START trial that convinced TrialNet to move forward with a larger low-dose ATG study. And in that larger TrialNet study of low-dose ATG versus placebo, we were able to confirm the observation from our pilot study that the low dose does in fact preserve regulatory T cells, exhaust T cells, preserve C-peptide, and actually lower A1C. And it reached that endpoint statistically, not just at 1 year, but actually at 2 years of follow-up. So again, for a 2-day infusion to induce a change in folks with stage 3 diabetes 2 years later is actually quite an impressive outcome observation. And at that point, that's when I think people started to rethink the notion that maybe rabbit thymoglobulin or polyclonal thymoglobulins in general would be good targets for trying to interdict the disease process of type 1.
So, this has led to the evaluation in the MELD ATG phase 2 study of trying to identify a minimally effective dose. So in that study, patients were given doses ranging from 0.1 mg per kg to 2.5 mg per kg, with the goal of measuring preservation of C-peptide at 12 months compared to placebo. These results were just presented last Friday at the EASD, and we're simultaneously published in the Lancet. So can you describe the key findings from the study and your overall impression?
Yeah. MELD, or minimally effective low dose MELD ATG study, was a study completed by the Enodia Network in Europe, and very nicely designed as an adaptive trial to explore multiple lower doses than 2.5 milligram per kilogram to see if they could identify the lowest possible effective dose. And they defined that effective dose as an early endpoint measure in the study based on CD4/8 ratio and Treg, T effectors, to predict which lower dose at the lowest end would potentially be beneficial. And so 0.1 milligram per kilogram did very little, not surprisingly. 0.5 milligram per kilogram actually was the lowest dose that met that early immunologic threshold. And so 0.5 milligram per kilogram became the other arm that got fully enriched for power. There were a small number of patients who got 1.5 milligram per kilogram, but that being a higher dose than 0.5 wasn't the minimally effective dose based on that early endpoint. And so that group did not get fully enriched for power, although there are some interesting findings from that small group. And then, of course, there was always a plan to keep 2.5 milligram per kilogram to try and confirm the prior work in a placebo group. So you effectively ended up with a three-arm trial after the adaptive part was completed, with a placebo group, a 0.5 milligram per kilogram group, and a 2.5 milligram per kilogram group in recent onset type 1s, age 5 to 25. And what they found was, first, they confirmed our observation from our pilot study as well as the TrialNet study that 2.5 milligram per kilogram of rabbit ATG is highly effective in preserving C-peptide compared to placebo, as well as reducing A1C, although they just missed significance for A1C in MELD study in the 2.5 milligram per kilogram dose. But the trend is certainly there. The new novel finding from MELD ATG is that even the 0.5 milligram per kilogram dose, which again met that early immunologic signal that we thought might predict response, did also preserve C-peptide. The point estimate was slightly lower than it was for the 2.5 milligram per kilogram dose in terms of absolute C-peptide preservation, but still met statistical significance. And the 0.5 milligram per kilogram dose also reached statistical significance with regards to reduction of A1C at a year compared to placebo. So a very exciting study and very exciting findings that confirm and expand on the notion that low-dose rabbit thymoglobulin can be effective in preserving C-peptide in new onset type 1s, and now sort of defining a therapeutic window of somewhere between 0.5 and 2.5. And there were some other interesting safety observations and perhaps even pragmatic observations from the 0.5 milligram per kilogram dose. The first being 0.5 milligram per kilogram is the day one loading dose when you get either 0.5 milligram or 2.5 milligrams per kilogram. So it effectively reduces the infusion to a one-day treatment. In the study, patients were placebo-controlled, so they all got 2 days of infusion, not knowing what they had gotten on day 2. The other, I think, exciting observation is that by using a 0.5 milligram per kilogram, they actually did see a reduction in the frequency of both cytokine release and serum sickness, which is one of the reasons we started lowering the dose from what was used in the START trial from 6.5 to 2.5, again, trying to find this Goldilocks zone. It looks like going a little bit lower could, in fact, be at least similarly efficacious, with a lower side effect profile and potentially, an even easier to deliver therapy. So I'm sure, following the MELD study, there will be a number of efforts to further explore, the 0.5 milligram per kilo dose. and just for completeness, I'll mention, while it's a very small subset, and so we can't really make too many conclusions, I think 6 or 7 patients who got 1.5 milligrams per kilogram before that arm was closed based on that early immunological threshold, not because it didn't meet it, but because it was a higher dose than 0.5, and the trial was intentionally designed to explore the lowest dose. That 1.5 milligram per kilogram group did extremely well with regards to C-peptide preservation also. So I think there's some potential for doses in the window of 0.5 to 2.5 to be, further explored.
Okay, and this question may require more analysis of the data, but have these results changed any prior held thesis about how rabbit ATG is able to achieve T cell exhaustion?
Not so much about how it might achieve exhaustion, but I think there was a big question around the notion of you might have to have lymphodepletion for thymoglobulin to be effective in type 1. Certainly with 6.5 milligrams and even 2.5 milligrams, you do see a CD4 count reduction that is quite long lasting. It takes, a full year for those values to completely normalize. Now, they're not low enough that they're particularly clinically meaningful, but we did not have any patients get secondary infections or have any problems with vaccine efficacy or anything like that after getting either the 6.5 or the 2.5 milligram per kilo dose. But you could see those patients had lower lymphocyte counts. With the 0.5 milligram per kilo dose, you actually don't get nearly as much lymphodepletion. It's very short term. And yet you still get the exhaustion signature. And of course, you still get the thing that really matters, which is C-peptide preservation with lower A1C. And so I think that helps put to rest the notion that however thymoglobulin works, it doesn't require lymphodepletion to see that end, which is important as newer versions of the drug are being developed that may not also induce lymphodepletion, but still have a robust exhaustion signature. That I think is going to continue to be, at least for the foreseeable future, an important marker of likely immunotherapeutics that can achieve the goal of preserving C-peptide and hopefully also lowering A1C.
Okay. So, in terms of a newer version of the drug, SAB Bio is developing a fully humanized ATG. They call it SAB-142, which is currently being evaluated in a potential registrational phase 2 study. So, what are the advantages of SAB's fully humanized ATG versus rabbit ATG, and how well does their phase 1 data demonstrate this?
Yeah, so SAB Bio has this very novel platform of a transchromosomic cow model. So a large animal cow that has the genes that control human immunoglobulin chains crossed into it. But otherwise, the cow maintains its cow immune system. And so you can immunize these cows with human thymocytes, and they recognize those as being foreign and form a polyclonal antibody response to all those thymic and T cell targets. But the antibodies that they produce in response to that are actually fully human antibodies. It's a very clever use of biology to generate this human ATG product. And so the advantage of this fully human antibody, polyclonal antibody therapy, is that it does not induce serum sickness at all. We fully eliminated that as a side effect profile from rabbit thymo by moving to this human ATG product. So that's a huge advantage, even though the lower dose of 0.5 milligram per kilo in the MELD study reduced the frequency of serum sickness. It was still, I think, around 40%. So it wasn't trivial compared to 0, which is what it will be, what it is with the human ATG. Another huge advantage, although theoretical, but one that we, of course, hope to achieve at this point is if we're going to convert preclinical type 1 diabetes, stage 1 or stage 2, to a chronic immune-mediated disease that we're going to manage without insulin, hopefully one day, we're going to need therapies that we can give repeatedly. Because as good as these therapies are, we know they're not completely inducing long-term tolerance. Even bone marrow transplant doesn't completely achieve that, and nobody's going to be talking about considering a bone marrow transplant to treat type 1 diabetes. But if you could have a therapy that you could offer every 6 months that would potentially indefinitely kick the can down the road or delay your progression to needing insulin for much longer than other therapies, that would be extremely attractive to physicians and families and people affected by type 1 as a therapeutic. And this drug gives that opportunity because, again, not only does it not induce serum sickness, because it's fully human, the antibodies don't induce anti-idiotype blocking antibodies. And those blocking antibodies do occur with teplizumab, and may be part of the reason that subsequent courses of teplizumab don't seem to, at least in the PROTECT study, don't seem to give a second inflection point in terms of delaying C-peptide loss any further in that population. I will hypothesize that with the SAB product that you may actually see a second inflection point because the antibodies will be fully functional and be able to do exactly as they have done when they were first given at the beginning of the trial that's planned. So those are, I think, exciting opportunities that the SAB Bio product provides, and I'm eager to see the clinical trial move forward that they have planned to test that notion first in stage 3 type 1 diabetes, and then hopefully with success moving back earlier in the disease process.
So, we do have phase 1 data for 142 in normal healthy volunteers. And what were your key takeaways of that data?
Yeah, really nice data in healthy volunteers. Thank them for being willing to participate in a study where they were going to have lymphodepleting drug given. But the surprising observation was that lymphodepletion that I frankly expected to see, as we see with rabbit thymo, is extremely short-lived with the SAB product. It actually looks much more like teplizumab in that nature, in that it is maybe marginalizing T cells, but allowing them to come back. And despite that, you still get this very robust exhaustion signature. The kinetics of it are a little different than rabbit thymo. It looks like the exhaustion takes a little bit longer to build up, but it looks like it actually reaches a higher absolute amount of exhaustion and may be more durable. Which again, for thinking towards a long-term therapy that you're going to want to give at some repeated frequency down the road, has significant advantages. So I read out the phase 1 data as being very supportive of the fact that SAB 142 does all the things that I would want rabbit thymoglobulin to do, with the added advantage from a safety point of view of not inducing long-term lymphodepletion while still allowing for a nice, robust exhaustion signature that to date has been the best marker of predicting response when it comes to C-peptide preservation and A1C reduction.
So I know there's still some phase 1 data yet to come for 142, including repeat administration. For that set of data, what would you hope to see?
Well, I hope to see that we confirm that, again, there's no serum sickness. They saw none at all with the phase 1 study, as we would expect. So, just to make sure that that continues to be the case. I'd like to see that the immune response is the same or even more robust when it comes to inducing an exhaustion signature a second time. What we want to not see is that there's some reduced immunologic response on a second or third round of getting the drug for reasons that aren't expected. That is what you see with teplizumab. That is what you see with rabbit thymoglobulin, with the added complication of maybe having even more robust serum sickness. And because we don't have to deal with that with the SAB 142 product, the notion of being able to give it multiple rounds is certainly very, very appealing.
And so now that we have the this set of data from MELD ATG, we've got some initial NHV data from 142. What do you think the read across is from all the data from rabbit ATG, including MELD now, is to a potential outcome for SAB 142's phase 2 study?
I think this study is as de-risked as you could possibly get in our space. You've got a drug that has a better safety profile than its original if we're going to call rabbit thymo the original, with immunologic signaling that looks to be very consistent with what we've seen in other therapies that have been effective, including rabbit thymo and teplizumab. And the ability to potentially redose without a blocking effect. So obviously we'll have to see the trial get completed and see what the results are before we can be confident that it is in fact as expected. But I can't think in my mind of too many other opportunities to apply a drug where we've known so much about the mechanism by way of an analogous therapy. And the only real differences with the new one are that it adds additional safety features and maybe even additional efficacy features. So, I would be very surprised if we didn't see a positive outcome of the trial when it comes to C-peptide preservation. And I expect that it will hit a glycemic endpoint because we didn't talk about it very much, but the fact that the 0.5 milligram per kilogram dose in MELD reached statistical significance with A1C is likely because of the serum sickness that occurs early on that requires a much higher insulin dose and induces insulin resistance that may be short-term beta cell toxic. And so I expect that for the same beta cell preservation, but with eliminating serum sickness entirely, and therefore not needing to expose patients to additional rounds of steroids, that patients are more likely to reach those glycemic thresholds. I'm also really excited to see the continuous glucose monitoring data from the SAB-142 trial. The data from the MELD trial are encouraging. They don't quite reach statistical significance with regards to the different study groups, but you can definitely appreciate as a clinician looking at them that you get more time in range with the folks who were randomized to the two effective arms. So I think that's where the field is likely to continue moving. And so even if for some reason you don't hit on absolute A1C changes, we might start to see that the CGM metrics are telling more of the story because you'll get less glycemic variability and more time in range, potentially even for A1Cs that are, on average, potentially similar. And that's going to continue to be a challenge, a good challenge, because as the field develops better and better, CGM and pump systems that can help most patients achieve A1C targets, our goal should be that at the end of most of these studies, the A1Cs are frankly similar, unless our immunotherapies are just so darn good that native beta cells will outcompete these, artificial systems. And that's, ultimately what we were trying to achieve. We just want to be so good at preserving those native beta cells that we don't even need those systems anymore because we prevent the need to progress to needing insulin.
And on the regulatory front, what do you think it's going to take for regulators to get more comfortable that, C-peptide is an appropriate marker for beta cell preservation?
Yeah, it's been a long conversation back and forth with folks at the FDA and experts in the field, TrialNet and others. And they finally have acknowledged that C-peptide is and should be a primary outcome measure, but they are still holding on to wanting to see some other measure of glycemic change that suggests a difference between treated and untreated patients. Again, my personal bias is that's an unfair expectation, especially as all these systems get better and better at achieving glycemic threshold. But nonetheless, that's still where they are now. And I think given, what we've seen from the TrialNet ATG study, the MELD ATG study, and now the preliminary data from SAB-142, that, even if the FDA holds tight to that notion that they want to see an A1C reduction, there's a pretty good chance they'll actually hit that endpoint. I just think that, if you're looking 10 years down the road, that's going to be harder and harder to do because the insulin pumps and CGMs are going to get better and better. And again, that's a good thing for our patients and families. But hopefully that will be enough to convince the FDA that they need to turn away from, requiring a glycemic change between treated and untreated groups to deem an immunotherapy successful, because we know from long-term studies that people who are even microsecretors of C-peptide, who have even tiny amounts of beta cell function around, even when they can't tell the difference in terms of their insulin requirements or frankly their A1C, those patients do better long term, have lower complication risks. And so, again, if the agencies are really interested in doing things that are best for patients, that is in the best interest of the patients. But obviously, companies trying to develop a therapy don't have a 40 or 50-year time horizon to show the agency that their drug was meaningful. And so I still remain hopeful that the ongoing conversations with key opinion leaders and the agency, and perhaps some changes in staffing at the agency, are going to ultimately result in them being more reasonable when it comes to accepting, C-peptide as the primary endpoint that may be enough to give a label to a drug.
Okay. So let's open up the aperture a little bit on other disease modifying therapeutics under development. Are there any that you're optimistic about?
Yeah, I mean, it's an exciting time in the type 1 immunotherapy space. We have a number of therapies that have shown promise. To date, rabbit thymoglobulin and teplizumab have generated the largest absolute preservation of C-peptide when you compare across different trials. But I think the data with baricitinib is very exciting. The JAK inhibitor class is, oral, well tolerated. And so that would be a nice way to be able to give a therapy that doesn't require an infusion at all and doesn't typically have any sort of short-term, big time adverse event associated with giving it. TrialNet is in the middle of completing its study of a couple of different JAK inhibitors, and the makers of baricitinib are going to further explore that drug in stage 3 and as well as stage 2. I think there are a couple other products that are in the immune modulating pathway that hold promise. So CD40 ligand pathway is a trial that's currently ongoing. That's frexalimab, a drug that's owned by Sanofi, and that has very promising results in multiple sclerosis and is currently being trialed in stage 3. I'll be eager to see the readout of that drug as well. Sanofi has in their shop an OX40 ligand combination approach, so it blocks both the CD40 and TNF alpha. So we're sort of seeing these combination single therapy style drugs. I think that one is very exciting and is starting in a trial right now as well. And I think you're going to start to see more of the combination therapy approaches that we've been pushing for well over a decade. Again, in trying to turn type 1 diabetes into a chronic immune disease rather than a disease we treat with insulin. It's not surprising that we likely are going to need, induction agents, probably like SAB-142, followed with maintenance therapies, perhaps like baricitinib or frexalimab or any other therapy, with reinductions when the immune system, rears its head again and we see that we're losing the battle. That would be a really exciting and interesting way to be able to treat these patients, much like we treat other rheumatologic or immunologic diseases. And I think we will get there as some of these therapies give us more of those options to do so. One other therapy I didn't mention that I think is also an interesting add-on probably is the verapamil story. So we just also at ESD had the Vera T1D trial report out, which did not meet the primary, but in the intention to treat analysis, but in the per protocol analysis, it did hit. Suggestive of what we've always thought was that there is something to verapamil. It may not be nearly as potent as thymoglobulin or SAB-142, but it may in fact provide benefit. It's not particularly immunosuppressing, or it may not be immunomodulating really at all, although the mechanism is still somewhat debated. And so again, it makes for a really nice adjunct or combination therapy to these other therapeutics. And in fact, there are trials that are ongoing with people getting rabbit thymoglobulin and verapamil in combination. And I think that approach makes a lot of sense and will continue to be explored.
Another area of a lot of development, but unfortunately a lot of failures, is cell therapy or cell replacement therapies. What's your view of these?
Yeah, made huge progress in the last several years, of course. We've finally gotten past the notion of them being complete science fiction, and now have cell therapies that really can, produce insulin and can have been put in people and have resulted in them producing their own endogenous insulin. But they are still very, very far from being ready for prime time and ready for delivery to the larger type 1 population. There's still a long, long way to go before many of these cell products are truly deemed safe and efficacious enough to consider giving outside of folks who, have type 1 diabetes complications, severe hypoglycemia, already are on immunosuppression for something else, so that the risk benefit starts to be justifiable for the cell therapies that require immunosuppression. But the recent exciting report of the first cell therapy that might not even require immunosuppression by way of changing the cell surface markers from Sana is certainly very exciting. But with an N of 1, again, it's quite a long ways away from being something that's going to be able to be given to our patients, and certainly not our pediatric patients, for many, many years.
And just maybe a final question on the regulatory side, in going back to C-peptide. Do you think it's possible that any of the regulators may allow measurement of C-peptide as an outcome measure that could facilitate a conditional approval or accelerated approval for stage 3?
Yeah, I do. I think it's a possibility. I mean, I'm hopeful that that actually happens, because I think that would be most appropriate. They haven't quite, allowed that to happen yet, but those conversations continue, and I know key opinion leaders continue to try to convince them through workshops that that's the right thing to be doing. And it'll only take one drug to get across the threshold in that way to, I think, then really open up the floodgates of lots of other therapeutics to be explored. I think it would bring a lot of, pharma interest into the space, and probably bring a lot of new drugs that we would be able to trial. So I'm hopeful that that will occur. But obviously, I can't speak for the agency, and don't know what exactly they're going to do. They certainly haven't said that they would give a stage 3 approval solely on the basis of C-peptide yet.
Okay. Well, great. Well, we've reached the end of our time here, but really appreciate you joining us, Dr. Haller, and sharing your insights. Also want to thank everybody in the audience who's joined us on the call. We will have a replay available in a day or two. So with that, we'll bring this to a close, and just want to thank you again, and have a good rest of your day.